So we are going to be talking about the vestibular system today, and mainly just focusing on kind of a quick overview of the anatomy of the vestibular system to help give you a little bit of a basis to then talk about the dysfunction and the clinical signs that we see when the vestibular system isn't working. I won't go very much in depth about particular diseases during this talk. It's more about just kind of identifying vestibular dysfunction. And a lot of these clinical signs and anatomy and everything are cross species. So, we will see similar clinical signs in large animals that we will in dogs and cats, even down to rabbits can get vestibular dysfunction. So a lot of these will translate over, and not just be applicable to small animal with some minor differences. So kind of a quick outline of what we're going to be doing today. So we're first going to go through basic anatomy and physiology of the vestibular system. Again, nothing kind of crazy, but just to get you an idea of some of the terms and organs that are involved particularly with dysfunction of the vestibular system. So we'll go through structures of the inner ear. We'll go through the vestibular cochlear nerve, particularly the vestibular branch of this nerve. We'll go through the vestibular nuclei, which are located within the brainstem, the cerebellum, and then we'll go through clinical signs of vestibular dysfunction, so peripheral vestibular disease versus central vestibular disease, and then the paradoxical vestibular dysfunction, which if you did listen to the neuroexam lecture, it did briefly mention in there as well. And then I just have a couple of cases that we'll go through to try and suss out, what we can see and try to apply what you've learned today. So this picture on the left is just a schematic of the vestibular system. So you can see that it is quite complicated, and it is very intricately involved in a lot of different aspects to the animal. So the vestibular system, coordinates with the muscles of the head and the face and the eyes, as well as the neck and the trunk. So you're always receiving input from your vestibular system so that your body and your brain knows exactly where every part of you is, and can coordinate all of those movements so that we're moving smoothly and continuously. So the inner ear. The inner ear has two major components. So you have a bony labyrinth, which is located within the petrous part of the temporal bone. And there are, within that bony labyrinth, there are three semicircular canals and the cochlea. And all of these structures arise from the vestibule, which is just a large opening in the bone. Within the bony labyrinth, there is a fluid called perilymph. So it surrounds what we call the membranous labyrinth, which is located within the bony labyrinth. And the membranous labyrinth consists of four fluid-filled compartments. Okay, so you have the semicircular ducts, you have the utricle, the saccule, and the cochlear duct. The utricle and the saccule are contained within the vestibule, so in kind of that large bony window. The semicircular ducts are within the bony semicircular canals, and then the cochlear duct is within the cochlea. And the cochlear duct and cochlea we're not really going to be talking about today because those are involved with hearing. So that's kind of a different talk there. Within the membranous labyrinth, it is filled with a fluid called endolymph, which is very similar to CSF. And it's very, very important because it's the flow of this endolymph that is creating increased or decreased signals that are being received by the brain. So you have these specialized organs within the membranous labyrinth. And the first one is called the crista ampullaris. And these are located at the base of the semicircular ducts, okay? So the semicircular duct on one end of each of them, there's three of them, and there's 3 of them, and they're positioned at 90 degrees from each other, so that any movement of your head in any plane will cause changes in one of the semicircular ducts. So that's essentially how your brain is receiving that input of where exactly your head is. So it's able to measure changes in both the X, the Y, and the Z plane because of how the semicircular ducts are positioned. And then there are direct mirrors of each other on either side. So that, again, not only can your body can tell what direction you're moving your head in, but also what side you're moving towards based on that flow of endolymph. But in one side of each semicircular duct, there is this dilation called the ampulla. And within the ampulla, there's this organ called the crista ampullaris. And this is a specialized cell, so it's involved in dynamic equilibrium, so particularly rotation of the head. And this organ is made up of specialized cells. And these specialized cells, called hair cells, have 2 different types of hairs on them. The vast majority of them have what we call stereocilia. And then there's a single kinocilium. And these are important because as the endolymph flows based on the movement of the head, that causes changes to the direction of these hair cells. And the hair cells are in direct synaptic relationship with the dendritic zone of the vestibular portion of the vestibular cochlear nerve, okay? So what happens is the endolymph flows and it will push the stereocilia either towards the kinocilium or away from the kinocilium. And if it's pushing these hair cells towards, well, that increases the signal that is being received by that portion of the nerve. If they're pushed away, just like you might imagine, that decreases the signal that's being received. And that is how your body kind of knows exactly where, what movement is happening and in what direction, because this system is constantly sending signals to the brain. So this is a, so dysfunction arises when there is loss of that signal being received because it's continuous. So within the utricle and the saccule, there's another specialized organ called the macula. So the macula utriculi is within the utricle. The macula sacculi is within the sacculae. And these are responsible for static equilibrium and are typically used more for up and down and side to side movement. So when you're driving in a car, it's going to be the macula that are involved with that because it's the same. So you have that initial acceleration and you have deceleration, but otherwise it's the same. And then these are also going to be used with up and down movement, so such as an elevator. And as you can see in the picture there, the macula are oriented in 2 different directions. So in the utricle, it is horizontal. So that's, again, going to be that forward and backward movement, such as driving in a car. And then in the saccula, it's vertical. So that's where you're going to get the up and down movement. So how your body can tell whether you're moving up and down. And it's also receiving input from gravity. So the macula is fairly the same as the crista in that it has hair cells, the same types of hairs. It's still in synaptic relationship with the dendritic zone of the vestibular cochlear nerve, but its makeup is slightly different. So it's got more of a gel-like substance sitting on the top of the hair cells. And on top of that gel, you have these otoliths, so the little stones in your ear that help with that movement. And those are important because when you're moving steadily, you're not going to be receiving input, right? So once you hit that acceleration in your car and you're no longer increasing or decreasing your speed, the macula don't receive signal anymore because it's not changing. So, and the otoliths are involved in that because they will shift And that shifting is what changes the direction of the hair cells rather than just relying simply on the endolymph, which is what the crista ambularis are kind of utilizing to receive their changes in signal. So the vestibular cochlear nerve, again, we're going to be talking about, the vestibular portion today, but it is made up of both vestibular and cochlear portions. So the vestibular obviously is involved with balance, but then you have the cochlear portion, which is involved in hearing. So the vestibular portion of cranial nerve 8, again, is in synaptic relationship with the hair cells of each of the crista ambularis, and then the macula utriculi and the macula saculi. They form a vestibular ganglion, which is still located within the petrous portion of the temporal bone. So all of those dendritic zones will leave. They get connected to the cell body within the vestibular ganglion. Then that sends the axons up into the brain, in where they will terminate in the vestibular nuclei, the majority of them, which is located within, they are located within the medulla and the pons, so in the brainstem. But a few of them will course directly into the cerebellum by way of the caudal cerebellar peduncle and terminate in the vestigial nucleus of the cerebellar medulla, and then the cortex of the flocculonodular lobe. And that's important to remember, and we'll get to why, but those are the axons that are involved with paradoxical vestibular dysfunction. Okay, so that's kind of where that comes into play and is in its importance. So the picture here is an MRI image, a transverse MRI image at the level of the membranous labyrinth. So if you see near the arrows, there's two kind of symmetrical bright areas. That is actually the fluid, so the endolymph within the membranous labyrinth. And what you can kind of tell is that they look like little rubber ducks, so that's kind of what we're looking for. But what you can see, it's somewhat difficult, I will admit, but with the arrows, you see these two little gray lines that are sort of leaving the back of the rubber duck there and going into the brain. That is the vestibular cochlear nerve. And again, you can almost make it out on the right side of the image that there's two branches. So one coming from sort of the head of the duck, as it were, and one coming from the back. And that suggests like the two branches before the nerve has merged as it enters into the bone and into the brain stem there. So that's what we're looking for on the MRI itself. And we look for, this in this case, it's symmetrical. So really when we're looking for a unilateral disease, we're looking for changes on one side over the other. And that's really what you have to do when you're looking at nerves on the MRI is kind of compare it to self. There's going to be a certain degree of individualism there with the size of nerves and such. But comparing one side to the other is how we would kind of determine whether there's changes associated with those nerves or not. So it can be very difficult in bilateral vestibular dysfunction to determine the true changes to those nerves. The lower picture there is just a schematic drawing of kind of what's going on. So the vestibular nerve there in synaptic relationship with the crista ambularis in both macula, and then the cochlear nerve, which is in synaptic relationship with the cochlea, and as they join to form the vestibular cochlear nerve. So the vestibular nuclei. So the vestibular nuclei, there are 4 paired vestibular nuclei. So there's 8 total. There's 4 on either side, and they're named based on their location. So they're rostral, medial, lateral, and caudal. And these nuclei form a continuous column on each side of the pons and the medulla. So again, they're kind of located within the brainstem, sitting right underneath the cerebellum. And from the vestibular nuclei are numerous projections into the spinal cord, the brainstem, and the cerebellum. And that is how your balance system coordinates with your the movement of your eyes, your neck, your head, and the rest of your body. And there's also projections into the front part of your brain for conscious awareness of where your limbs are. So at any given moment, you may not be thinking about it, but at any given moment, you know exactly where your arms and your legs are in the position of your body, so you can adjust accordingly. So the other thing, so what the second image there is just kind of showing some of those tracks. The only one that I'm going to particularly talk about, because really it's not all that important in clinical practice, but the one kind of area that I do want to talk about is called the vestibulospinal tract, and the vestibulospinal tract is necessary because that is how your brain and through your vestibular system are coordinating with the movement of your limbs. So your vestibular system is involved and does have control over your extensor and your flexor muscles. So we're not talking about fine movements. We're going to be talking about postural muscles. And what it does is the ipsilateral, so the same side, that vestibular system is involved with facilitating the extensor muscles on that same side. And then they are inhibitory to the flexor muscles on the same side, okay? So basically, when you have a dog or a cat that has vestibular dysfunction, if you pick them up off the ground, they will get stiff on the side of the lesion. And that's because of that lack of control. There are then collaterals that end up decussating, so they cross over to the other side, where they are inhibitory to the extensor muscles on the contralateral or the opposite side. And the way that I remember this is if you're falling, your body is going to stiffen the side that you're falling to try to push you back on balance, right? So it wouldn't make any sense for your body to then inhibit the extensor muscles on the side that you're falling, because that's just going to perpetuate your falling. So that's how I like to remember it. So if I'm falling over, my body is going to stiffen up to try to push me back onto the other side. So, in that example, if I'm falling over to the right, my right vestibular system will facilitate. So the extensor muscles on my right side, so I get stiff. So it's going to inhibit the flexor muscles, but then it doesn't want me continuing to push to the left. So it's going to inhibit the extensor muscles on my left side. So I relax. So when I get pushed over, I'm not pushing against myself. So that's kind of how I keep that straight in my mind. So the cerebellum, the cerebellum is involved with the vestibular system, like I alluded to. There are some collaterals that end up going straight into the cerebellum. So again, axons from the vestibular nuclei and vestibular ganglion will project directly into the cerebellum. They enter into the cerebellum through the caudal cerebellar peduncle. So there are 3 cerebellar peduncles. They terminate in the cortex of the flocculus and of the hemisphere, and then the nodulus of the vermis, so also known as the floccular nodular lobe. And then they do have some collaterals that extend into the fastigial nucleus. And these are involved with coordination of the position of the eyes, the neck, the trunk, and the limbs with the position and the movement of the head. So your cerebellum does not initiate movement, but it smooths it out. So it is what's coordinating your ability to reach out and touch something without overextending or underextending. So that's kind of the job of your cerebellum. So it's involved in quite a lot, but it's more of a coordinator and an organizer rather than an initiator. So this is why with cerebellar disease, we can see balance system dysfunction. So the most common cerebellar sign that I will see, or cerebellar dysfunction that I will see, is due to a vascular event, so a stroke, to the rostral cerebellar artery. That's kind of a rough overview of the anatomy of what we're talking about here. So clinical signs of vestibular dysfunction. So we're going to go through abnormal posture, vestibular ataxia, nystagmus, both a normal nystagmus and an abnormal nystagmus, particularly talking about jerk nystagmuses, strabismus, postural reactions, and then we're going to talk about bilateral vestibular system disease because it's a little bit different, and then paradoxical vestibular system disease, okay? So abnormal posture. So because of the involvement of your vestibular system in the movement of your head and your neck and your body, loss of function is going to create a loss of coordination between these systems, okay? So the most common sign that we will see is a head tilt, okay? So that is where if you look at the dog or the cat or the rabbit or the large animal straight on, one ear will be lower than the other. And the side, so with peripheral vestibular, so unilateral vestibular dysfunction, the head tilt will be towards the side of the lesion in the vast majority of cases. So the lower ear points to where the side of the dysfunction. So if you have a head tilt and the dog is tilting to the left, so i.e. the left ear is lower, that would indicate a left-sided lesion. So dogs will also, and cats will also tend to fall / lean to the side of the lesion. Excuse me. And again, that's because they're kind of off balance and sort of falling to that side. So again, in the example of the left-sided head tilt, we would expect that animal to also be falling to the left as it's walking. In some cases, you can see the neck and the trunk flex laterally to kind of form a concave kind of shape to the animal. Again, towards the side of the lesion. So the Yorkie is kind of a bad example because he's circling, but if you stopped him, he still had that turn to the right and kind of that body curve to the right there. And as you can tell in that top video there, these dogs will often also circle to the side of the lesion. And with vestibular dysfunction, they are more often than not in these very tight circles like this Yorkie is demonstrating. So forebrain disease will also cause circling, but they tend to be very wide and will kind of skirt the edge of the room, whereas vestibular dysfunction, they're usually the dogs that are either very, very rapidly or circling very tightly to a particular direction. In that bottom video, if you watch it, and it will continue to kind of repeat, you can see this dog as it stands there, it sort of has this general sway to him. So he's moving back and forth, even though he's not actually moving. You can see his kind of trunk and his back legs sort of swaying. You can see the muscles tensing there. That is very, very common with vestibular dysfunction, particularly of the cerebellum, okay? Because, again, this system is coordinating your movement. It's also going to give you that ability to stay on balance when you're not moving. So a lot of times with dysfunction, we will see dogs and cats again, just stand there and sort of have this, what we call truncal sway to them. And again, that's a particular, it's vestibular dysfunction, particularly of the cerebellum. So I do have a question. I don't know, I don't want to give you the answer. So I hope you can still see it. I just want to be able to see the chat here. So I want, if you guys could, I'll move on. Yes, sorry, I just saw the question in the box. I'm trying to use my arrow and for some reason it doesn't show up when I am in presenter mode. At the end, if there's a particular question about a diagram, I'm more than happy to kind of go back into a view like this, and then we can go back and point stuff out. More than happy to do that. So I did want to ask you guys a question, and you can just put your answer in the chat. So we'll give you a couple of minutes to answer. So I want to know if you guys can remember, and we did talk about this in the neuro exam lecture, but what are the 3 different types of ataxia that we can see? So here are your options. If you just want to type in kind of A, B, and C, A, B, C, or D in the chat there. And then when we have some answers, we'll go back to kind of the presentation and show you what answer it is, and then we'll move forward. Right, so we have 1 for D, proprioceptive, cerebellar, and spinal. We'll vote for A, so spinal, cerebellar, and vestibular. Another one for A. Lots of A's. One for B, so cerebellar, vestibular, and proprioceptive. Another one for A. Another one for B. All right. I'll give you guys 2 more minutes, and then we'll move forward. Couple more for A. About 30 more seconds.
It's CA.
Okay. So the answer is actually B. So the reason that it's B is, so it's quite common that people will talk about spinal ataxia, but the correct term would be proprioceptive. So you have cerebellar, vestibular, and proprioceptive ataxia. And we're going to be obviously talking about kind of cerebellar and vestibular today. Proprioceptive is what you would get with spinal cord dysfunction. But those are going to be your 3 different types of ataxia. So cerebellar, vestibular, and proprioceptive. So ataxia, like we just talked about, the 3 different types there. So patients with vestibular ataxia use their eyes to help maintain balance, and they will get worse if they can't see. So you can tell in this video that you can kind of see the dog fell to the right. He just looks drunk when he's walking. So he's ataxic in all 4 legs, so a tetraataxia. He's kind of crossing over midline. He's sidestepping. So those are very classic signs for a true vestibular ataxia. This dog, I would, in his clinical record, if you looked, I defined him as a cerebellar vestibular ataxia because of the truncal sway. This is the same dog in the previous slide, 2 previous slides, where he was just standing there kind of swaying. So there has to be cerebellar dysfunction involved. But this portion of the video is very classic for a vestibular ataxia. So when talking about, if you're unsure if they are ataxic, so some dogs are very, very subtle. If you lift their head to reduce kind of what they can see, again, that ataxia will get worse. Use caution because they may fall over. And be very, very careful in cats because cats will kind of tend to freak out and they will just extend their claws to try to grab onto anything, which the nearest softest thing may be your arm. So do use caution with cats, particularly when you lift them up, if you're suspicious about vestibular dysfunction. You can do this in large animals. However, you must use extreme caution when blindfolding a large animal because they can fall and hurt themselves or obviously hurt those around you. So never tie a blindfold to a halter of a horse or a cow. So you can slip a blindfold underneath the harness or the halter if you need to, but you should never tie it to the halter so you can't get it off because they will start to panic if they have vestibular dysfunction and someone can get hurt. So nystagmus. So a nystagmus is a rapid eye movement, and you have normal nystagmus and you have abnormal nystagmus. And abnormal nystagmus can be spontaneous or positional, okay? Normal nystagmus is what we call physiologic nystagmus, and this one is involved when you move the head to side to side, you will see a natural kind of flicking of the eyes, and that would be a normal nystagmus, and you should always test for that. So there are 3 main types of nystagmus, so a jerk nystagmus. So you have horizontal, rotary, and vertical. So disorders of the peripheral vestibular system, so those involving the inner ear, the quick phase of a horizontal or rotary nystagmus will be directed away from the lesion, okay? It is convention to talk about a nystagmus based on the fast phase. So if I tell you, hey, I have a dog that has a horizontal nystagmus to the right, I'm talking about it's got the fast phase to the right, the slow phase is to the left. Or if you guys are talking to me about a case, that is how you would present it to me. And that would tell me, okay, the horizontal, if the nystagmus is to the right, then I would expect a head tilt and all of the other changes to the vestibular system dysfunction that we can see to be on the left side, because that would be suggestive of a left-sided lesion. Disorders of the central components, so the brainstem and the cerebellum, can cause any of the 3 nystagmus, so horizontal, rotary, or vertical. They may also change position. So I've had dogs that have had a horizontal nystagmus, you flip them on the back, and it will turn rotary or vertical. That's very, very classic for a central vestibular lesion. And then with central, the nystagmus may be directed away or towards the lesion. So it's not as easy to define. A vertical nystagmus, a true vertical nystagmus will only be seen with central vestibular dysfunction, but it can be very, very difficult because a lot of times vertical nystagmus will have a rotary component to it, which can be peripheral. So I would never localize central just based on the nystagmus alone, unless it's changing. So these videos, so this cat here that's got pretty severe hydrocephalus, you can see the vertical nystagmus. You can kind of see this rapid eye movement up and down. It also has a strabismus, which is an abnormal eye position, but you can see that up and down movement. So that is a true vertical nystagmus suggesting a central lesion. The second video here, so the husky down there is kind of darting all over. So this dog, when you put him in lateral, he had a horizontal nystagmus when he just looked at you, but when you flipped him on his side, he has a horizontal nystagmus that has a little bit of a rotary component to it. And you can see his fast phase is kind of subtly to the left. So there's a slow correction to the right, but the fast phase is to the left there. And again, he had a central lesion because of the changing to his nystagmus when you tipped him over. This last video that I want to show is kind of a slow motion video. So this is a rotary nystagmus. So you can see that the dog's eyes are rotating along the central axis. So that's the way that I kind of describe it to the owners is it's like the eyes are flicking back and forth between 12 and 1 o'clock on a hand. Okay, so it's kind of rotating this way. And you can see, so the dog will slowly rotate to the left and then the fast phase is to the right. He blinks when he corrects, but kind of slowly twitches to the left and then corrects quickly to the right. So that would be a rotary nystagmus with a fast phase to he's correcting to the left. So that's a rotary nystagmus with a fast phase to the left, suggestive of a right-sided lesion. Just let you watch the videos for a couple of seconds just to get an idea. Oops. Restart those for you. All right. So strabismus. A strabismus is an abnormal eye position when compared to kind of the orbit and the palpebral fissure. So you can particularly see positional strabismus when the head and the neck are extended because the globe should stay right in the middle of the eye. Now, this is a slight species differentiation between large and small animal, because if you lift the head of a horse or a cow, we don't expect their eyes to remain perfectly centered. So you can have a little bit of ventral displacement of the eyes, so it can look like a ventral strabismus. However, that is a normal variation for large animals that's not present in small animals. The strabismus of the vestibular dysfunction can mimic the ocular motor dysfunction. So you have to be careful in kind of using the rest of your exam to differentiate between ocular motor nerve dysfunction and vestibular dysfunction. So your ocular motor nerve controls your pupil. So it's the parasympathetic innervation to your pupil. So you're going to see anisocoria potentially with ocular motor dysfunction, but it also is involved with a lot of the extraocular muscles. So you can see a strabismus with loss of the ocular motor nerve. There's other nerves that are involved in the eye position, and we just don't have the time to kind of go through all of that. So again, we talk about that in my neurologic exam talk. So if you want to go back, if you haven't seen that or want to refresh your memory there, more than welcome to go back and rewatch that to kind of get the idea. I also have a chart in there about which cranial nerves are involved with the extraocular muscles. So again, a vestibular strabismus will be on the same side as the vestibular dysfunction. So if we keep going back to our example of the dog with the right-sided head tilt and the right-sided lesion there, he would have a strabismus in his right eye, or I would expect to find a positional strabismus in the right eye. And again, that in farm animals, their eyes don't always elevate completely, so don't overinterpret that. Particularly for us small animal folks, if we happen to have to do an exam on a large animal, it may kind of throw us a little bit. So postural reactions. So this is another thing that you want to incorporate in your neuro exam. Really should be doing an entire neuro exam regardless of where you think the problem is. So the vestibular system, the peripheral vestibular system, is the only system involved with movement that does not interfere with postural reactions, okay? If you have an inner ear problem that is causing balance issues, their postural reactions will be normal, okay? You do want to test them, and you can test them by doing the proprioceptive placing, so the paw replacement, hopping, Be careful when you hop if they are off balance, because they may not catch themselves and they may fall over. So make sure that you're supporting them very, very well. But you can do tactile placing and visual placing. So again, that's where you need to use caution when lifting the animal up, because cats, again, can kind of have this tendency to try to grip onto whatever is closest to them. And then you can also do hemi-walking, wheelbarrowing, and extensor postural thrust, all of which are testing that conscious proprioception. So if you have a dog or a cat with vestibular dysfunction and you test their proprioception and it is normal, does not guarantee that it's a peripheral lesion, but it's more suggestive, it does not guarantee that it's not a central lesion, but it is more suggestive of a peripheral lesion. A dysfunction of the central vestibular system, because it is involved in the brainstem, and the brainstem is very, very small, it will cause postural reaction deficits. So if you have a dog or a cat and you're suspicious of vestibular dysfunction, and you flip their paws over and they have deficits, this is automatically central. May still be an inner ear infection that is extended into the brain, but it is central. So those dogs and cats, you should refer, if you can, any case of vestibular dysfunction, because even if you localize peripherally, they may not be peripheral. I myself have been burned by that before. But if they have postural reaction deficits, this is involving the brainstem and the cerebellum, and they would be a higher candidate for referral if, again, possible. So some unique syndromes here. So we can have bilateral vestibular dysfunction if both ears are not functioning. Animals will have these very, very wide head excursions. So we kind of joke and call them the Stevie Wonder. So they'll just be extending their head really far from one side to the other. And in this video, you can see this cat doing that. So you can see how, he's kind of moving his head to the right, and then will swing it very far to the left, and then goes back and forth. If you have bilateral vestibular dysfunction, your brain is not receiving any input from either vestibular system, okay? Which means it can no longer coordinate the movement of your eyes. So you will not find a normal or abnormal nystagmus with bilateral vestibular dysfunction, because there's nothing for your brain to base it off of. It's not receiving any input, so it doesn't think that you're moving, which means that it's not going to have a nystagmus. So you will not find or see a nystagmus with bilateral vestibular dysfunction. And if you try to induce one, a normal physiologic nystagmus, by grabbing the dog and moving them side to side, you will not induce a normal nystagmus with bilateral vestibular dysfunction either. You can also have what we call a head rebound phenomenon. This is typically more likely to be present with cerebellar dysfunction. But if you lift their head and very quickly remove your support, a lot of these dogs, so make sure that you're doing it on a soft surface, a lot of these dogs and cats will no longer be able to catch their head, so they will just drop and hit the floor. So that can be suggestive. Just because you don't have that doesn't mean that you don't have bilateral vestibular dysfunction, but that is one test that you can do if you're suspicious of this. So the one that kind of throws everyone for a loop is the paradoxical vestibular dysfunction. And this one is where the head tilt and the loss of balance are directed towards the side opposite of the lesion, okay? And this is involving particularly the caudal cerebellar peduncle, the floccular nodular lobe of the cerebellum. That's it. So these kind of on our side, when we get a dog or a cat that has paradoxical vestibular dysfunction, it's very easy for us to localize because those are the only areas that are going to create this. And it's because you're losing that disinhibition from the opposite side, or from the side of the lesion, which means that if you're losing the disinhibition, your body is receiving more signal from the side of the dysfunction than the other side. So the head tilt is always away or is always towards the side of reduced signal. So in these lesions, because your brain is kind of getting more information from the side of the lesion because of where these are, the head tilt and everything is going to be away because now the normal side seems weaker. The biggest thing with paradoxical vestibular dysfunction is that it is central. So it is central vestibular disease. They will have postural reaction deficits. So, and they will be on the side of the lesion. So always go with the legs. Okay. So if you have a dog that has a head tilt to the right, a nystagmus to the right, but when you do their postural reactions, they have deficits on the left side, that would be a left-sided paradoxical vestibular dysfunction, okay? Lesion is left-sided because the paw replacement, so the proprioceptive deficits are on the left. So always go with the legs. So we'll kind of go through, so again, I'm going to kind of exit out here. We're going to go through some case examples. So put your answers in the chat, and we're kind of close to our hour, so we won't spend a whole lot of time on these, but I just have 3 of them for you to go through. So we'll kind of go through the neuro exam, and then you guys can just kind of put your answer in the chat, and then we'll go through these somewhat quickly here. So the first one is a 2-year-old male neutered domestic short hair, and if you can't answer, that's fine. Just kind of listen, and you can always go back through this and see what you've got. So he is bright and alert with appropriate mentation. He's ambulatory with a tendency to kind of list or fall to the right. Mild cerebellovestibular ataxia with a right thoracic limb hypermetria, so an increased tone in the right thoracic limb. Mild to moderate head tilt to the left. Absent paw replacement in the right thoracic limb with delayed paw replacement in the right pelvic limb, and normal paw replacement in the left thoracic and pelvic limbs. There's absent hopping in the right thoracic and pelvic limbs with delayed hopping in the left thoracic and pelvic limbs. It's got normal reflexes and and appears comfortable. Somebody just asked about deafness. This isn't really a talk to discuss kind of deafness. So we're going to be focusing on vestibular dysfunction here, not really deafness. So you can use a bear for hearing, but that would be kind of a different conversation and a different talk. So the question is, based on that information, where would you localize this cat to? All right, I have a vote for right peripheral. I have a left central, right central vestibular, paradoxical. Do 30 more seconds and then we'll move on. Another vote for A. All right, so This cat was demonstrating right central paradoxical vestibular dysfunction. So these are the MRI images from him. So you can see this large lesion within his cerebellum. So that was what was giving us kind of the paradoxical component to that. Owner did not elect to go forward with a biopsy, so we are treating him for a suspected abscess, and he is making kind of steady improvements. But this was a classic case of a right paradoxical vestibular. So case number 2 is an 11-year-old female spayed miniature schnauzer that's bright and alert with appropriate mentation, ambulatory with a moderate vestibulocerebellar ataxia and listing to the right, mild head tilt to the right with a subtle horizontal nystagmus, fast phase to the left. Remainder of the cranial nerve examination was normal. This dog had absent paw replacement in the right pelvic limb with normal paw replacement in the thoracic limbs and the left pelvic limb. Normal reflexes and appears comfortable. So where would you localize her? Again, we'll give you guys about 45 seconds or so, and then we'll keep moving on. Right, got one for right peripheral. Remember, with peripheral vestibular system dysfunction, you will not see any postural deficits, okay? So the fact that she has some means that it cannot be peripheral. Kind of narrowed it down for you, so you got 50-50. All right. Yes. So this dog had a right central vestibular lesion. So again, you can see here MRI images from her, and you can see kind of, or sort of barely see here, there's kind of a poorly defined hyperintensity within the rostral cerebellum. This is very, very classic for an infarct or a stroke to the rostral cerebellar artery. Very, very common in schnauzers. So this dog did make a full recovery. So they usually do very, very well with this. But yes, she was right central vestibular. So the last case is a 2-year-old female spayed miniature poodle mix that presented bright and alert with appropriate mentation, ambulatory with vestibular quality tetraataxia, no appreciable weakness, and a mild left-sided head tilt. A mild, on the cranial nerves, normal menace response, normal palpebral reflex, and PLRs bilaterally. Had a left positional strabismus and positional rotary nystagmus with a fast phase to the right. Proprioception was normal in all 4 limbs, normal reflexes, and appeared comfortable. So where would you localize her to? Vote for left peripheral. Another vote for left peripheral. Okay. I can go back. There's her signal, man. Back to the choices. 30 more seconds. All right. So I would agree with you that she localized to left peripheral vestibular, and that's what I did. And she was improving on medications at the time, so we had a suspected inner ear infection, so we continued to treat her, again, localizing left peripheral. Well, she presented 9 days later after having a seizure. And the reason that I bring this case up is because dogs can be very, very difficult, and cats can be very difficult. And we have studies to show that we are not always the best at localizing peripheral. So this is why I made the comment earlier about referring even peripheral vestibular or dogs that you think have peripheral vestibular dysfunction, because it may be wrong. So like I said, I was incorrect in this case in localizing her peripheral because she had a central lesion. So these are her MRIs, and you can see on the right side, there's a lot of inflammation. So this kind of bright whiteness that you can see that was causing her vestibular signs and later causing her seizure. And again, the reason that I bring this case up is because there was a study in 2020 that looked at 93 dogs, 62 of them localized central and 31 localized peripheral. They then MRI'd them all. 61 out of 62 dogs that were correctly identified as central, which means that we are about 98.4% correct in dogs that we localized central had a central lesion. However, only 24 out of 31 dogs were correctly identified as peripheral. So that means that 7 dogs that we localized peripheral actually had central lesions. So we were only about 77.4% accurate in localizing peripheral dysfunction. So I bring that up because we've all missed it. So what I don't want you guys to do is beat yourselves up if you localize something peripheral, maybe the history and everything fit with nicely with an inner ear infection, but the dog ends up coming back later and then localizing central or starts to develop central signs, because it is missable, and it's, I guess missable may be the wrong word, but a lot of times they don't show the classic signs of central vestibular dysfunction. So it's also why you may see, if you ever do refer a case to a neurologist, even if it localizes peripheral, we've still recommended an MRI to make sure that there's not a central lesion. And it's usually because of this paper that, when we talk to the owners, we're like, look, looks peripheral. However, there is a slight chance that we are wrong. So if you want to be absolutely sure, the MRI would be the way to do that. So I wanted to bring this particular case up for that reason, but you all were correct in your localization initially. So we will end there. So if you guys have any questions, so what we can do is we should probably just put them in the chat just so we're not having a bunch of people kind of talk over each other. So if you have a particular question, if you want to just type it out, and then I'll be happy to kind of go through that. We'll give you guys about 15 minutes. I know it's late for you, so I don't want to drag this on for an extended period of time. So it's, yeah, like I said, we'll give you about 15 minutes or so to answer questions. If nobody has any questions, then we'll end it, and I'll let you guys get back to your evening. But
ഒരു ഇംഗ്ലീഷുകാരൻ്റെ ക്ലാസ്സാണ് പുള്ളി.
Okay, we've come to the end of the Look down.
Yeah, and if no one has any questions now or thinks about something later, you guys can always send us an email. So I do have one. So paradoxical vestibular syndrome was fascinating. How do we differentiate paradoxical from regular? So that's a good question. So really it's going to be based on your postural reaction, so proprioception. So if I have a dog that has, you know, a head tilt and nystagmus, and I test the postural reactions and they're absent, I automatically know that it's peripheral. And then, I automatically know that it's central. And then looking at those, if the postural deficits are on the left side, but the head tilt, the falling and everything is to the right, then I know that that animal has paradoxical vestibular syndrome because the proprioceptive deficits are on the opposite side of the head tilt. So that's how you would differentiate paradoxical from kind of a quote unquote regular central vestibular dysfunction. So your main difference between peripheral and central. So another question, talking about one more time, the difference between peripheral and central. So they can be very, very difficult to differentiate, but some things that you will see with central vestibular disease that you will not see with peripheral is a changing nystagmus based on the position of the head, postural deficits, so proprioceptive deficits, and a true vertical nystagmus. Those all will be central vestibular disease, not peripheral. So the treatment is directly dependent on what the cause is. So you can have inner ear infections that can cause vestibular dysfunction. You can have tumors that can cause dysfunction. You can have strokes. You can have idiopathic vestibular disease or old dog vestibular disease. I've seen hypothyroidism cause vestibular signs. So there's quite a long list of things that you can see that can cause vestibular dysfunction. Same thing if we ever talk about seizures, there's lots of different causes of seizures. Yes, we'll talk about, you can talk about things that you can do to treat the symptoms, but really you're trying to identify the underlying cause to then treat that to help the dysfunction go away. Now, with vestibular dysfunction, there are a couple of things that you can do regardless of the underlying cause. And every case that I have, regardless of the cause of the vestibular signs, a lot of those dogs and cats will go on Cerenia, so meropitant, if they are vomiting. It's quite rare, actually, for them to vomit because of vestibular dysfunction. But if the owner has reported that they vomited or they seem nauseous, then I will do a day or two of Cerenia. The thing that seems to help them the most, and I'm honestly not sure if you guys can get this in India or not. I know in Canada they can't. But there's a drug called meclizine that you can use. So it's in Dramamine or Bonine here in the US. And it is like an anti-vertigo drug. And that seems to help the dogs very, very much. And I can swear by it. I myself have had vestibular dysfunction. And meclizine was the only thing that was allowed me to actually even be able to stand up at all. So no matter how mild the signs are, most of my cases will be started on meclizine just to make sure that the dogs are comfortable. And that will also a lot of times, rather than vomiting, I'll usually have owners telling me that they just are inappetent and don't want to eat, and meclizine often can help with that. And the dose for meclizine isn't specific, so I usually go If a dog is less than 5 kilograms, I'll give them about 12.5 milligrams. 5 to 15 kilograms, they get about 25, and then higher than that, I'll do either 1.5 or 2 tablets of the 25 milligrams.
What is the content of maclozine?
What was that?
What is the content? What it contains maclozine?
I'm sorry, I can't really hear you.
You want to know the name of the drug, that what it contains?
Meclizine is the name of the drug. I don't know if you guys can get it in India or what it would be called, but it would be a motion sickness drug. So we would it's an over-the-counter medication here in the US, and it's usually in kind of the travel sickness section because that's usually what it's used for in humans. But the drug name itself is meclizine, and I can type it in here in the chat so you guys can look it up. But like I said, I do know in Canada they don't have it.
So what it contains? Maclozine. It's an anesthetic,
I'm sorry.
Yeah, the name of the medicine and drug is same. It's not anesthetic. It is being given for motion sickness, like for human being.
Yes, correct. Yeah.